Our next presenter is Drs. Chapin White and Chris Whaley. They are our researchers from RAND Corporation. I'm so excited to have them here today. We've been working closely now for 2 years together on price transparency, and it's just been a phenomenal experience. All of you know Chapin, but I'm going to ask you to do your own introductions, if you will. And Chris, will you be coming up here as well, or? Okay, well, it'll just be Chapin White then. But if you want to stand up and be acknowledged for your research. Thank you so much.
Great, thank you. Thank you, Gloria. So my name is Chapin White, and I'm a health economist with the RAND Corporation. And the RAND Corporation is a 501c3 nonprofit research organization dedicated to the public interest. And I've been there for 4 to 5 years. I came from the Congressional Budget Office and then a think tank in Washington, D.C. called the Center for Studying Health System Change. You know the old joke about an economist? An economist is somebody who knows the price of everything and the value of nothing. Well, I'm here to talk about prices, but I also want to start off by saying that the hospital industry is a different industry. When I think about the hospital industry, I think about prices. That's the first thing that comes to mind. But then in the back of my mind, I also think about an episode 10 plus years ago when our son Nate was first born. He was 3 weeks old and got a respiratory virus, and my wife, who's a physician, was smart enough to say, this baby's really sick and we need to bring him to the hospital. And he almost died on the way to the hospital. They went to Children's National Medical Center in downtown Washington, D.C. They saved his life. And when I saw the bill, it was, I don't know, 15, 20,000. I thought this was the biggest bargain in the history of humankind. I would pay anything for the joy of my life, who is my son. So hospitals are an industry. We work in a market-based economy, but it's an industry that is entwined with people's lives in a way that's special and different. I want to acknowledge that right off the bat. That said, let's get into talking about prices, because the hospitals are also entwined with people's pocketbooks and their financial well-being and their wages and their ability to pay rent, make their car payments, and stay out of bankruptcy. So we're going to try to keep both those sides of our brains active as we go through this. So just to set the context, this is a simple 2-bar graph. This is healthcare spending per person per year in the US. That's the red bar. It's around $10,000. It's gone up a bit since these data were put together. And then the blue bar is the average among the OECD. These are high-income countries. This is, exchange rate adjusted. It's about $4,000 per person per year among these high-income, high-functioning comparison countries. That's a gap of about $6,000 per person per year. That's real money. Think about what we could all do with $6,000. We have 5 people in my family. That's $30,000 a year. We could do a lot with $30,000 a year. The explanation, there was this famous paper that came out about 15 years ago titled, "It's the Price is Stupid." And I love papers in academic journals where you don't even have to read them. You just see the title and you know the punchline. Well, the update came out. It's still the price is stupid. And I have the citation at the bottom. It's not that we're getting more healthcare services. It's not that we're sicker. It's that for every service we get, we're paying so much higher prices in the U.S. compared to all these other high-income, high-functioning countries. I want to add a little twist to that, though. It's not that prices are uniformly high in the U.S. When you start burrowing into the price problem, there's one area that stands out. First, it's the prices that private health plans pay that really stand out as being so much higher than what Medicare and Medicaid are paying. And secondly, it's the prices being paid to hospitals. Hospitals are a huge line item, and that price gap is especially big. So when you ask, why is the U.S. so different? Why is the U.S. an outlier? It's the private hospital prices, stupid. That's that's the context when I think about hospital prices. So first I want to get on the table what we know already before we got into RAND 1.0, before we got into RAND 2.0. We already know a lot about what's going on with the prices paid for hospital care by private health plans in the US. First, those prices are higher and have been growing faster than Medicare. The red line here is price per inpatient stay paid by private plans, rising over time, and the price per inpatient stay paid by Medicare, which has been, after you adjust for inflation, pretty flat since the mid-90s. Oh, thank you. Sorry. I was referring to the preview slide. Okay, I'm going to try to cover up the preview slide on my monitor here. So for a long time, private health plans and Medicare were traveling in parallel. And then starting around the year 2000, the prices of private health plans have been paying hospitals started drifting away from Medicare. The second thing that we know about private hospital prices is that when you look at spending increases in the private sector for hospital care, it's all price. It's not utilization. And Suzanne previewed this. These are price and utilization trends for the privately insured from the Healthcare Cost Institute. And this is a public report, freely downloadable. Go to the website and download these data. Both on the inpatient and outpatient side, the prices going from 2012 to 2016 are between 15 and 20% higher. Utilization has been falling over that time. So this is a small shining example of that bigger context. We're not getting more services as time goes by. We're just paying higher and higher prices, and that's where the spending increase comes from. So the other fact that we know about private hospital prices is they vary a lot from one city to another city, and even within a city they vary a lot. And this is a screenshot from a study that we did a couple of years ago, funded by the National Institute for Healthcare Reform. This is really the precursor to the study and the findings that we're talking about today. This study used claims data from the UAW and the big three automakers to look at hospital prices. And lo and behold, there was wide variation from one city to another, and within cities, there was wide variation as well. Indianapolis, not coincidentally, is at the far right end, the highest priced city among the cities that we could include in the study. That led directly to Gloria and Dave Kelleher reaching out to me and getting this whole ball rolling. We also know that prices tend to be higher at must-have hospitals, hospitals with big market share, hospitals that have a large number of beds, hospitals that are part of big systems. And that gets back to the consolidation point that Suzanne previewed. We also know from RAND 1.0 that hospital prices have been rising rapidly in Indiana through mid-2016. So that sets up, and here's a screenshot of a price variation chart from RAND 1.0. Each of these bubbles is a hospital. The systems are ranked low to high, and the bubble is showing outpatient prices relative to Medicare. There's a huge spread across hospitals, across systems, and those price trends were going up through 2016. So what did we not know after RAND 1.0? Is Indiana normal? That was the question that kept coming up. Well, yes, private prices are higher than Medicare in Indiana. That's because hospitals need to cover their costs because of Medicare underpayment, and Indiana is not really that different. That was some of the feedback we heard. We also wanted to know what happened after mid-2016. Are prices continuing to rise? And then we wanted to look at hospitals and hospital systems in other states beyond Indiana. And then the big picture question is, are the prices that different hospitals and systems getting, are those in line with the value of the care they're providing? That all led to RAND 2.0. Now, the inspiration for the study and the analysis we're doing comes from the Medicare program. So in the Medicare program, you can go online and download reams of data with all sorts of different cuts. If you go to, if you Google Medicare provider utilization and payment data, you can get files that will say for every hospital and for specific DRGs or outpatient procedures, you can see exactly how many of those services Medicare bought, you can see what the provider charged, and you can see what Medicare paid. It's pretty simple. You can take those freely available data from the Medicare program, and you can line up all the hospitals. This is Indiana, and they're too small to see on this figure, but every hospital is named, and you can rank them low to high. Not only that, in the Medicare program, these prices they're on the table, and you can also figure out exactly why each hospital is getting paid what it's paid. The rules and regulations, the legislation are all on the table, and you can figure out exactly why each hospital is getting what it's getting. That's the inspiration for these RAND price studies. We want to see what private plans are paying in the same way that we can see what Medicare is paying. So that all leads to RAND 2.0. Now we're transitioning into the current study and trying to unlock the secrets of whether Indiana is normal. And I'll give a preview. Indiana is normal in a lot of ways, not in your hospital prices. Okay. So our approach is to get claims data from what I think of as a coalition of the willing. So these are self-funded employers who are willing to jump in and have their claims data sent to us. These are state-based all-payer claims databases. If we could get them for free or for barter and trade, or and if we were allowed to report hospital-level prices, we use the APCDs. We also worked with, and we're not discussing names on the health plans, but health plans help provide claims data as well. We're measuring prices in two ways. The first and simplest is relative to the Medicare benchmark. So what did private plans pay as a percent of what Medicare would have paid for the same services from the same facilities? The second approach to measuring prices is to say, what's the dollar amount per case mix weight? And a case mix weight is a measure of the intensity of the service. So it's trying to take all the complicated set of services that a hospital provides and boil it down to $1 amount per service adjusted for the intensity of the service. The other core concept behind this study and this report is we're going to make the results public. We're going to put a report online that anyone can download that has prices for named hospitals and named hospital systems. For the RAND 2.0, we're also creating a set of private reports for self-funded employers that takes their specific claims data and says, here are the hospitals your employees are going to, here are the prices you're paying to those hospitals. So that's an additional dimension that we added on for this study. Okay, so I mentioned these two price measures. There's relative prices, which is relative to Medicare, and there's price per case mix weight. The relative prices, and I promise this is the worst slide out of all of them, but the relative prices, what's nice about using Medicare is, as the benchmark, is Medicare adjusts for case mix, so that's what kind of services are being provided. It adjusts for wages, so Indiana, compared to Manhattan, there's a wage adjustment that goes into Medicare. It also adjusts for if a hospital's a teaching hospital, they get higher Medicare reimbursements. If a hospital's treating a lot of indigent patients and providing a lot of uncompensated care, it'll get a bump up in its Medicare payments. That addresses a lot of the justifications for one hospital having a higher price than another, and so it's nice to bake that into your benchmark. The other thing about relative prices is you can look at relative prices for inpatient and outpatient, and they're directly comparable. If I tell you you're paying $20,000 for DRG 470 on the inpatient side and $5,000 for APC 0512 on the outpatient, those are watermelons and kiwis. So the relative price concept you can compare across service lines. Price per case mix weight, if you're a non-teaching hospital in a low wage area, you probably would rather be judged based on dollars per case mix weight because maybe maybe in dollar amounts, maybe your prices are lower than the big academic teaching hospital downtown. That's a legitimate concern with the relative price approach. So we're calculating prices per case mix weight as an additional dimension. In the results that I'm reporting, I'm just focusing on relative prices. The price per case mix weight will be in the public report when it comes out. So why compare to Medicare? This is kind of an emotionally touchy subject, and so I'll go through these responses and I'll try to anticipate maybe the responses to the responses. So why Medicare? First, Medicare is the largest purchaser of healthcare in the world, and in terms of dollars of healthcare services bought, it is far bigger than the entire UK National Health Service. It's far bigger than the German healthcare system, which it's debatable whether that's a single purchaser, but Medicare is just the 800-pound gorilla of the US healthcare system, and the US healthcare system is the 800-pound gorilla of healthcare worldwide. Not coincidentally, oh, and Chris Whaley said, well, what about United Healthcare? Don't they have more enrollment? No. Medicare's up to 56 million. United, I think, was about 50, and a lot of that is Medicare Advantage. In the Medicare Advantage program, Medicare is really buying those services and setting prices, and that's all flowing through to the premiums and the prices that United pays for its MA book of business. Okay. So not coincidentally, Medicare sets industry standards. If Medicare says you're going to bill using UB04s, hospitals bill using UB04s. If Medicare says you're going to bill using ICD-9s, ICD-10s, or else we're not going to pay you, lo and behold, hospitals switch to ICD-10s and physicians. It sets industry standards, and Medicare's requirements flow through all of the claims processing, all of the transactions, and its tentacles reach even beyond its direct purchasing. The other feature of Medicare is its prices are, and the methods that it uses to set prices are empirically based and transparent. Transparent, if you go download the Federal Register on looking at one of these inpatient hospital final rules, you'll see exactly how they're paying, and you'll see a rationale for why they landed on that approach. Medicare prices, this is the really sensitive bullet. Medicare prices are intended to be fair. Medicare has long ago reimbursed hospitals for their costs. That then shifted to paying hospitals prospective rates and having those rates grow over time. Medicare prices are set to increase over time, taking into account wage increases, so the increases in the costs of the hospitals doing business. It also bakes in some adjustment for productivity, so Medicare is assuming that hospitals are going to get a bit more productive over time. That's where the prices come from. Now, I know that when you look at what private plans are paying and what Medicare is paying, and there's this massive gap, it's easy to say Medicare is radically underpaying. I go back to the figure way at the beginning. Back in the day, Medicare and private plans were right next to each other, and something changed. And it's not that Medicare prices have been dropping radically relative to overall inflation or wages, it's that the private plans diverged. So that's my takeaway in a nutshell on whether Medicare prices are fair and why there's that huge divergence between Medicare and private. Medicare also uses a whole raft of value-based payment approaches baked into its payments. They're adjusting for readmission rates, for hospital-acquired conditions, for overall value-based payment measures. This all makes it the natural benchmark to use for measuring hospital prices. So, and the title of the slide was a 4D price scan. So what are the 4Ds? We're going to be looking at private hospital prices, and we're going to be making comparisons over time. That's the first dimension. Across states, that's the second. Among named hospitals and named hospital systems, that's the third dimension. And then the fourth dimension is across service lines, inpatient and outpatient. Those two service lines are radically, fundamentally different in their price patterns, and so we're gonna tease those apart. So let's give a preview of the findings. And why are we doing a preview? And Gloria was, hammering on us to release the final report at the conference, and this is just a preview. Why is this just a preview? Getting these claims data is, and I knew it was going to be painful. It was longer and more painful, and we are still hammering out DUAs with health plans. That's a finding in and of itself. The mere fact that self-funded employers want their data included does not magically make it so. And there's a lot of, let's see, some health plans have been terrific. Some health plans have been wary and have been routing this claims data request and these DUAs up through the legal stratosphere, and we're still working it out. The final report, when it comes out, will include more claims data, more hospitals, and more states that I'm reporting here. So these numbers, the numbers that I'm showing will change a bit. If you take a national number and add in some new data, it's going to move up and down a bit. This is a pretty solid preview of what we'll be showing, but there's going to be more hospitals and more states in the final report. What's that? Yeah, Indiana, we're all set. Yeah, by the grace of Liz Drury. Okay, so the scope of the study. We're looking at prices for hospital inpatient care and hospital outpatient care. We're not looking at professional services. We're not looking at physician services. We're not looking at SNFs. We're not looking at rehab, long-term care, prescription drugs, DME, any of that. We're focusing on the two really big line items, hospital inpatient and hospital outpatient. Hospital outpatient includes emergency department visits, imaging, ambulatory surgery, and so on. The states, I think we have about 22 here. Montana and Wyoming, I've asterisked. Their data are coming. We finally worked it out with a health plan who objected to having their secrets revealed, and their secrets will not be revealed, but the hospital prices will be revealed for Montana and Wyoming. We're focusing on the years 2015 to 2017. For some of our states and some of our data contributors, we can go farther back. For some, we go up to 2018, but 2015 and 2017, we have solid data from all of our data contributors. And so far, we have 1,222 short-stay general medical surgical hospitals included. So that's about 10 times as big as round one. We're on track for round three to be the whole shebang, right? In terms of the number of services, we have about 310,000 inpatient stays, 13.5 million outpatient lines, and that's about north of $12 billion in allowed amount. Here's the first finding. This is just describing the data, but that allowed amount is comprised of $6 billion on the inpatient side, $6.3 billion on the outpatient side. So, and I think Suzanne, you previewed this as well. There's been this massive push to move services into the outpatient setting. Well, congratulations, you've done it. Most of your spending is on the outpatient side, and the outpatient side is where you really need to be paying attention to your pricing. Okay, the funders include the Robert Wood Johnson Foundation, the National Institute for Healthcare Reform, self-funded employers, and this isn't meant to be exclusionary, but by design, we did not take funding from health plans or hospitals. We want this to be employer-led and employer-targeted. Okay, so here's the first punchline. When we take all of these hospital claims data, reprice them using Medicare's groupers and pricers, and look at commercial relative to Medicare, we're at 223% in 2015, and that has risen to 229% in 2017. So that's private plans are paying 230% of what Medicare would have paid. This is case mix adjusted, local wage adjusted, adjusted for teaching, uncompensated care, and so on. This is the big picture relative price. So now let's dig into state level results, and let's look at the question of whether Indiana's normal. So I've ranked states low to high, and I'm just checking my time because I want to leave some time for questions and feedback. We've ranked states low to high. The red line shows the state's price relative to Medicare. The blue circles are inpatient prices relative to Medicare, and the triangles are outpatient prices relative to Medicare. So there's a bunch of interesting findings that leap out here. First is that there's more than a twofold difference between the highest price state and the lowest price state. So highest priced right here in Indiana, lowest price Pennsylvania. And I was telling the folks from Indiana, hang on, Montana and Wyoming, there's hope yet. I mean, you may not end up at the very far right again. We'll see. There's an interesting set of states at the bottom. Pennsylvania, Michigan, we have heavy representation in our claims data from Michigan. Louisiana, New York, and Kentucky. Those are the five low-end outliers. At the high end, Colorado, Maine, Texas, Wisconsin, and Indiana. The other thing that really pops out is in some states, their inpatient and outpatient prices are pretty close to each other. So that's Michigan, New York, Tennessee, Massachusetts, and New Hampshire, and Maine. Those states are either in the middle or tending toward the bottom end of the price scale, and I think that's probably not coincidental. In all the other states, the inpatient and outpatient prices are hugely different. Exactly why this happens, I'm not sure. There are local market dynamics and local market histories that going on in these states that have led to these very different outcomes. The why, I think, is up to the employers and their health plans and their hospitals to work out, but there's clearly a different approach to paying hospitals in these states at the low end versus the high end, and in the states where inpatient and outpatient are tied to each other versus the ones where they're fundamentally different. So let's look at trends over time by state. So remember, including all the states and all the data, prices are trending up relative to Medicare. Let's look at what's going on state by state. So I included just 5 states where we have really robust claims data and where we have a nice, meaningful, stable trends. Again, at the high end, here's Indiana. Indiana has been ratcheting up from over the last several years. So rising from 277% in 2015 to 295% in 2017. So not only is Indiana at the high end, they seem to be peeling away from the rest of the pack. Michigan is really interesting. Michigan, again, is a low-price state, and their prices relative to Medicare have actually been ratcheting down over the 2015 to 2017 period. So if anything comes out of this, everyone from Indiana should be talking to folks from Michigan. What is going on in Michigan? And we have some super on-the-ball folks who are running enormous health benefit plans in Michigan. The other state, Colorado, has been rising, maybe not as steeply as, well, about as steeply as Indiana. Ohio, New Hampshire, pretty flat. So that national number, that national trend does not tell you what's going on in your state. You need to dig into your state and dig into your local market to figure out where your levels are and if you're trending in the right direction or not. Okay, now I promised that we would talk about hospitals and health systems. So in this slide, what we've done is taken all of the claims data for all of the hospitals, grouped hospitals into systems. So these are hospitals that can be in multiple states that are jointly owned, and then we've calculated prices relative to Medicare for each of these hospital systems. And we've ranked the systems low to high. We have in the mid-50 number of large hospital systems. And here you can see that the relative prices range from right at Medicare to 400% of Medicare. So we saw a lot of variation state to state. There's even more variation from one hospital system to another. And I promised we were going to talk about which hospital systems had the highest prices. So at the very far right, and if you read RAND 1.0, you probably know who's going to be at the very far right. This is the Parkview Health System, and I have a Google street map shot of the main facility in the Parkview Health System. Parkview's getting, as a system, not just the main facility, as a system is getting 400% of Medicare. That's including inpatient and outpatient, and that's about $270 for inpatient and about, what is that, $530 for outpatient. So Parkview, now there's hope. Montana and Wyoming are coming along. Maybe there'll be some system out there that, but for now, Parkview Health System is the highest price system out of all the claims data that we have on hand. Now, the point of this isn't to just make people feel uncomfortable about prices. The point of this is to kick off a discussion about value. And one of the goals in putting this price report together and naming hospitals and naming systems is to say, okay, what are the quality metrics we can get our hands on to see what kind of value we're getting for our spending. And one of the sources that Gloria previewed is the CMS Hospital Compare website. They have a star rating system where for any hospital, at least Medicare certified hospitals, you can look up whether they get 1, 2, 3, 4, 5 stars. 5's the best, 1 is the worst. So I've taken our hospital prices and I've grouped hospitals into 3 buckets: low priced on the left, medium priced in the middle, and high priced on the right. High is 250% of Medicare or above, medium's 150 to 250, and low is below 150. The red are the 5-star performers. These are the unicorns. These are the ones who, in CMS's judgment, aggregating dozens and dozens of individual quality metrics, these are the hospitals that are doing a really good job. The 1-stars are the dark blue at the bottom. These are the ones that are doing unusually poorly on these quality metrics. There's a couple ways you can look at this figure. The first way to look at it is to say, I want my employees to go to high-priced hospitals, and lo and behold, high-quality hospitals. I want my employees to go to high-quality hospitals. Lo and behold, high-quality hospitals are disproportionately represented in the high-priced category. And you also want your employees to avoid the 1-star hospitals, the really low-quality hospitals. And lo and behold, if you send your employees to the high-priced hospitals, there's basically no 1-star hospitals in that bucket. So there does seem to be something going on between price and quality. But my bigger picture takeaway when I look at this is what Gloria started out with. We're looking for best quality at best price. And there's a huge chunk of high-quality, low-priced hospitals out there. That's really where you want your patients to be going to, these 4 or 5-star hospitals in the low-price category. It is possible to pay reasonable prices and send your patients to a high-quality facility. Now, it's going to take a lot of work to get there. This isn't you don't wave a magic wand and have all your patients going to that quadrant that you want them going to, but it is possible. It's not as if employers are facing an impossible dilemma of giving up adequate quality in order to save money on health benefits. So let me get into 3 quick takeaways. The first is that markets, this is a market, it's a special market. but it's a market, and markets need information. You cannot have buyers being blinded to the prices they're paying. And Uwe Reinhardt, who's kind of a famous health policy guru who passed away a year or so ago, described hospital pricing as chaos behind a veil of secrecy. And he was natively German, but had a way with words, and I don't think anyone else has summed up the hospital market better than Uwe. There's also this quip where there's mystery, there's margin, and I think several people claim ownership of that quote. If you're buying from consolidated health plans who are contracting in secret with consolidated hospitals, let's look at how that's worked out for you. How did that work out? We are paying for hospital care the highest healthcare prices anywhere in the world. And that's a statement about the US nationally. And then if we zoom in on Indiana, what you end up with is another quip, ABI. When big employers are thinking about where to set up a new manufacturing plant or a new facility, anywhere but Indiana. The reason being, every time their employees in Indiana go to the emergency department, they're paying thousands of dollars extra compared to going to the emergency department in a different state. Indiana prides itself on being a business-friendly environment, and the hospital pricing in Indiana has gotten to such a point that it's undermining the competitiveness of the state, and that's. I'm thinking of my managers and handlers back at Rand who wanted me to be not inflammatory and just say the facts. Those are the facts. Okay. The other thing, the other fact I want to put on the table is employers who are operating self-funded plans have a legal fiduciary duty to spend their benefit dollars prudently. And if you're entrusting health plans to cut secret deals with hospitals, and if you're walled off from your own claims data and walled off from the contracts and the pricing that you're paying, you're paying blind and you're flying blind, and you have a legal responsibility to spend prudently. It's not the health plan's money, it's not the hospital's money, it's your employees' money, and you're spending it on their behalf, and you have to spend it prudently. And I don't want to get into scare stories about CFOs and HR heads who've been personally named in lawsuits, but that happens. Okay. Second takeaway, when we talk about prices and how they're trending, how they compare, it's important to get square in our heads. It's not just the price numbers that I'm reporting that matter. It's how you pay. So what do I mean by that? When Medicare pays a hospital, they start with a base dollar amount. On the inpatient side, it's in the $8,000 to $10,000 range, and then they adjust it based on which hospital provided the service. They adjust it based on how complicated the service is. They add in outlier payments and bonuses. But it all starts from that base dollar amount. That base dollar amount is growing over time, basically with inflation and with the downward adjustment for productivity. How are self-funded employers paying? Well, first, that's secret. Self-funded employers are generally not able to look at the contracts between their TPAs and their hospitals. So that's a problem right off the bat. But what's clear is there's a mix of multiple of Medicare payments. There are some fixed rates in there, but private health plans and self-funded employers are paying a lot of discounted charges for hospital services. And discounted charges, this is the sanitized version that my managers at Rand were okay with. Discounted charges allow price inflation and wide variation. Discounted charges are an abomination. They are a Stone Age payment approach where you're taking your bank routing number and you're handing it to the hospital CFO. Hospital charges are, this is a quip that I think has many owners, limited only by the CFO's imagination. If you take one imaginary charge number and multiply it by one imaginary discount number, who knows if you're paying a fair price? Who knows if it's inflating at a reasonable rate over time? You have to start with a base dollar amount, make adjustments on top of that, and make sure that base dollar amount is growing at a reasonable rate, not 5% a year when wages are growing at 2% a year. That unsustainable wedge is how Indiana got where it is today. Okay, employers have two big picture options here. The first is to impose market discipline, that is act as buyers. And when you act as a buyer, you've got to know how you're paying and how much you're paying. And that means my very first step to imposing market discipline is move away from discounted charge contracts and move toward fixed rate contracts. If your plan can't or won't tell you whether they're paying discounted charges, that's a huge problem right there. You need to know how you're paying and how much you're paying. Find out what those fixed rates are and compare it to benchmarks from other states, benchmarks from Medicare. You could bring in international comparisons if you want to start looking at whether your prices are reasonable. The other uncomfortable fact is to impose market discipline, you need to be willing to move, to do something different. You need to be willing to move patients away from low-value providers, and you need to be willing to switch TPAs. If the TPA can't get you a fixed-rate contract or negotiate decent prices, you need to be willing to switch. Now, Maryland is a living example of somebody who took this on and survived to tell the story. And foreign purchasing alliances. The employer coalitions in this group are the kernels of not just information sharing, not just muffin eating, but action, buying together, buying in bulk, and throwing your weight around. That's impose market discipline. For the market to work, buyers need to act as buyers. The other big picture option is to say hospitals are too consolidated. This is too complicated. We're done with this. I want our employees to be enrolled in a Medicare buy-in. I want the federal government to set up a Medicare for all, or I want my state to step in and start setting hospital rates on my behalf so I don't have to worry about this anymore. And the managers at RAND thought this was a really inflammatory political statement. I don't think so. This is the fork in the road, and it's 2019. Election is right around the corner. Spring may not be, but the election's right around the corner, and it is totally legitimate to say consolidation of healthcare providers has gone too far. Pricing is out of control, and the reins are so out of our hands we can't even get it back under control. That's a legitimate conclusion. I think that's probably not the conclusion a lot of people come to, or a lot of people want to come to, but it is legitimate to say this situation has gotten out of control. We're going to hand it over to a program, the biggest purchaser in the world, that knows how to buy healthcare and knows how to set prices. That's a legitimate option. So those are my takeaways. I hope they haven't been too inflammatory. The acknowledgements, there's a huge list of people who've really been instrumental. Some on the health plan side, we're not naming health plans as a matter of policy, but there are health plan folks who've been hugely helpful. But mainly Gloria and Dave, thank you for reaching out to me, reading that health affairs paper, and getting this ball rolling, because this should be the new normal, that when we're talking about hospital prices, we're not banging our heads against walls of trade secrecy or claims data ownership. We should be talking about what's fair, what's right, and how we, in a market, in a special market, can move to a better outcome. So thank you all for making this an interesting study, and I hope we have some time for reactions or comments. Yeah, great. Yeah, and
Technical question?
yeah.
When I was working on my paper, which you would, Mike Siebold,
Right.
I'm with Clare and River Partners. I'm a former president of the Blue Cross plan. in working on my paper about this subject last year, I found, when looking at this case mix indexes,
Yep.
they were going up at about 5 times the rate of the national average, about 3.6 on average between 2012 and 2018 and 2017. Is there any impact of that on the analysis in terms of whether if the case mix indices are going up at that rate?
Yep.
Does that impact at all and diminish the impact of how high that could be?
Yep.
In other words, does it understate how high the payments really are?
That's a great question. So, so the Medicare as a benchmark starts with their base rate. And could you bring up the slides again? Sorry. Medicare starts with the base rate, adjust for the facilities, adjust for case mix. So Mike is asking about this case mix adjuster, and on the inpatient side, Medicare uses DRG weights for case mix adjustment. And if a hospital manages to move a patient into a higher DRG, they get more revenue from Medicare. And case mix has been rising rapidly according to your study in Indiana. So what I would say is, there's an evolution of progress in payment policy, and you need to take care of the biggest problems first. The biggest worst problem is paying discounted charges. Once you move away from discounted charges, then you can start talking about the base rate, the facility adjustments, and case mix adjustments. Once you've gotten to that stage of evolution, this is all like Suzanne has this kind of 50-year forward-looking kind of evolutionary outlook. A lot of payment is still kind of back in the murk and hasn't kind of climbed out of the swamp yet. Once you get out of discounted charges into case mix adjusted fixed rates, then you need to start tracking your case mix. And the bigger picture phenomenon there is upcoding, and the fact that hospitals and physicians and EHR vendors and Medicare Advantage plans and all of the actors in the healthcare system that have a financial incentive to do so have started paying a lot of attention to how they code diagnoses and how they code procedures. And so this is a second order problem that I think in some markets it's totally spot on to be focusing on case mix and why that's been growing so quickly. And I'm not sure what the auditing procedures are or the forensic procedures are to try to figure out why case mix has been growing so rapidly in Indiana. But this is kind of an advanced problem to be focusing on. It's the right problem if you've moved to that multiple Medicare approach. But I'd be interested to hear what you think is behind the rising case mix in Indiana.
So it was going up at about 3.66% a year, and most of that has been heavy investment, I would suspect, in revenue cycle management, because when you went off of old DRGs to MSDRGs, you opened up a whole range of coding opportunities, and some hospitals put a lot of money into it, and others didn't. What surprised me is it was pretty uniform. Just about every hospital in this market had that kind of growth rate. I mean, they're averaging almost, some of these hospitals, over 2. Which typically in Chicago, we were like 1.6.
Right, so these are DRG relative weights averaging over 2 compared to...
Right, yeah, over the MSDRG. And of course, the problem then is that inflates the Medicare payments, which would then therefore make the relative to the commercial look lower than it really is.
Right, okay. And this is exactly the kind of question that employers should be asking to their health plans. Are we paying a multiple of Medicare DRG weight-based inpatient rate, and if so, what's our average DRG weight? And because that feeds right into Medicare, and if you're paying multiple of Medicare on the private side, it feeds right into your payments as well.
Yeah, one more comment, not to, these are public benefit organizations, and they're not taxed. So it's something, hospitals making this kind of profits, and the question needs to be asked is, where's this money going?
I think we know some of the answers to that, but Chapin, great. Look forward, Chris Skizak, Houston Business Coalition on health. I applaud you for what you've done here. I look forward to seeing the reports, and I'm sure there'll be a breakdown by state, by hospital, et cetera. In looking at this, do you break down in any of the graphs that you plan to create profit and not-for-profit hospitals?
We haven't so far. If you're interested in including that, we could include that.
Well, the only reason I say that is one of the, there's enough evidence that shows that the for-profit hospitals do a little bit better job of managing Medicare spend than not-for-profits, or being able to make those ends meet.
Right.
The employers have bought into, we have to pay so much more because we just can't make it on this. We just can't, and we know that's not quite true.
Right.
So I think that'd be an interesting sidebar.
One, let me, just to prove that we really do have data. So I brought a printout. You know, these are our 1,222 hospitals, and every hospital has the hospital name, the Medicare provider number. If you Google Medicare provider number and plug in this 6-digit code, you'll be able to find out if it's for-profit, not-for-profit, and reams of other information about that provider. So whether we include for-profit, not-for-profit, government-owned status, the goal is to give you a starting point to start layering on all the dimensions that you're interested in particular, because of, you know, the particular market or whatever dimension you want to be interested in. We want this to be compatible with and something that you can sync up with that other data source. Yeah.
Chapin, Cheryl DeMars with the Alliance in Wisconsin again. I have a question. You went back to a slide that showed this pretty dramatic divergence between what Medicare was paying and what the commercial market was paying.
Yep.
Do you have a theory about what created that divergence?
What created that divergence? That's a great question. Right. Well, I think hospitals realized they could, and and they could, especially if they put themselves in a must-have position, if they managed to have service lines that were unique in their area, or if they started gobbling up physician practices in their area. I mean, if you go back to the early 80s, hospitals were getting cost reimbursement from the private side and Medicare, and then with the managed care revolution, hospitals were now in the position of negotiating their rates with private plans, and this figure unfortunately doesn't go back to the 80s, so I'm speculating a little bit, but I think in the early days of managed care, health plans were able to get bigger and bigger discounts by steering volume fairly aggressively, and then hospitals retrenched, figured out how to defend themselves against the aggressive managed care organizations, and then my take on it is, starting about 2000, hospitals started to have the upper hand in these negotiations with managed care organizations, and for the last 20 years they've been cranking away at it.
Technical question, should be really quick.
Okay.
For the large system slide that you had, are individual health, or are systems that are in different states done separately? So Ascension has, you know, a large Michigan contingent. Ascension has a large Indiana contingent. Are those broken out separately?
Right. So the way we're going to present it is Ascension Health has a bunch of hospitals in different states. We'll have a hospital system price measure, and then for each hospital within that system, you'll also be able to see that specific hospital's price measure, so that if you want to, with some fairly straightforward manipulation of the spreadsheet, you can say Ascension in Indiana is at this price level. Ascension in I don't know what other states that system's in is at this different price level. So you'll be able to aggregate it up to the system state level with the public report.
All right, thank you.
Yeah.
I'm Jim Knutson with Aircraft Gear Corporation. I think you answered it, but I was already up here and I felt kind of funny walking back without it. So, but on Cheryl's question on when the red bar took off, I wonder, Suzanne was talking about consolidation starting right about that time, and it seems like we lost, as purchasers, we lost a lot of our leverage when that happened, and so that was just an observation.
Yep.
I have a question also about consolidation. We're part of a large national.
Could you say your name and organization?
Yeah, my name's Ben Park, and I'm with American Health Network, Optum Care, which is the large national organization. When we look at physician reimbursement in Indiana, what we find is it's the lowest in the nation, right around Medicare rates. And if you look at the Medscape survey done in 2018, Indiana is the highest state in the nation in terms of physician compensation. And so I think the role of vertical consolidation may be really underappreciated. There's only about 11% of the physicians in Indiana now that don't work for some sort of hospital system. So it makes it a little hard to have a narrow network if you take out all the physician capacity at the same time when you try to narrow it. You don't. There's not enough docs left to see the patients. So
And are you thinking that the physician compensation, so they're getting low rates on their professional fees, but they're getting revenue by being part of a larger health system?
oh yeah, they're being subsidized dramatically by the hospital systems.
Yep.
And so it makes that the obvious choice for docs. And I wondered what you thought about the relative role of vertical consolidation versus horizontal consolidation in driving price.
They both matter, and let's see. I think Suzanne, you brought up regulatory enforcement actions to slow or block consolidation. Historically, the FTC and the DOJ have kind of cast a blind eye on vertical consolidation on the theory that integration of hospitals and physicians, they're operating in different segments of the healthcare sector, and so in general, that gets a pass under antitrust scrutiny. I think that's changing a lot, just because there's more and more evidence coming out that when a physician practice is bought by a hospital system, first they start billing as a hospital outpatient department, which jacks the prices up right away. Second, they start piggybacking onto the hospital system's negotiating leverage, which further increases prices. And third, they start referring only to the hospital system that they're a member of, whether it's high or low quality, whether it's high or low priced. That ends up increasing prices for the services that physician then orders or refers patients for. All of that evidence is just accumulating, but how do you unbake the souffle? I mean, the system we've got is just so heavily vertically consolidated, and like you're saying, the notion of taking a dominant health system and all of their physician practices and cutting them out of your network entirely is painful to contemplate. But that's where we are with if we want the market to work. That's what we have to contemplate. Go.
Lakshmi Agarwal. I'm a provider competing against Parkview Health Systems. We have the dubious distinction of being part of the 11% providers that are still standing independently.
Could you say what organization you're with?
Fort Wayne Medical Oncology and Hematology. So we
Great.
are an oncology group, independent physicians. So we are the elite with the bullseye on our back because we compete against a hospital system, as you can see. Two issues. One is the antitrust. Why is the government not paying attention to this with all the consolidation? But the second is stark exemption that hospital systems have. So when the physicians are bought by the hospital, they have an exemption under the Stark law because they can refer to the hospital system. Billing goes higher and higher and higher, and that exemption is coming up for a permanent vote, which means it'll be a permanent exemption. Is anybody paying attention? This was a New England Journal article just a month ago about ACOs not saving the system money.
Right.
It did not save the system money. On top of that, more power is being given constantly. So I really, hats off to you guys. You give the little David some power at least, because there's no advertising dollars. We do not have the money to advertise that we are a high-value, low-cost provider. We just don't have that kind of money.
So for background, so Pete Stark was a congressman. I think he was chairman of Ways and Means, and enacted laws that prohibited physicians from getting kickbacks for referrals. That everybody agrees with that conceptually. And then what's happened is when a physician becomes owned by or employed by a health system, now they're getting performance bonuses and they're being tracked on leakage, and that's not technically considered a kickback, but
Correct.
boy, it sure feels like one.
It is,
Right.
yep, and
And-
navigator is the dirty word that the hospitals are using. I mean, the patients feel the navigator is wonderful, but never ever will the navigator give an option outside the hospital.
Right.
And sure enough, they're being bonused by preventing leakages, but where is the oversight for the
Right.
system?
I mean, there's a whole, legislative, state and federal legislative dimension to this that is beyond what we're talking about in this session. Maybe it'll come out in the breakout sessions, but you've hit on exactly the kind of issue to be tracking.
My name's Michael Hafey. I'm in that 11% also. I'm a dermatologist, and I'm in Lima, Ohio. And for 33 years, I've been on the board of an independent practice association there. We haven't accomplished a lot in that time. I won't go through all of that, but the light's been going on in our minds in the last year as well. And because of this tremendous acceleration of physician hiring by practices in our market, certainly the majority of the physicians within an hour's drive of my city. And we have two we're a small town, but we have 17 orthopedic surgeon group, neurosurgeons, heart cath. One of my friend's patients just had a cardiac ablation procedure in Lima, and the hospital presented him with a bill of $120,000. Aetna or Anthem paid $22,000, but that's beside the point. My point is, I'm trying to conceive of a way that providers can interact with payers more directly. I mean physician providers. This business that the hospital buys a little practice in a rural town and calls it a provider-based clinic, and all of a sudden they're billing with ops codes, it's beyond ludicrous. It's also, it drives independent physicians to hospital employment because they really can't compete in that environment very well. You know these things. So the thought in my mind is that with steerage, if people went to providers who were preferentially going to attempt to get procedures done in the outpatient world, which is getting harder and harder. Every cardiologist in my county is a hospital employee. But there's other procedures too. I think there's a lot of room for opportunity in figuring out nitty-gritty details between a provider group that really wants to stay independent of hospitals and payers who are not being raked over the coals by independent physicians, but by hospitals, to put it bluntly.
Yeah. That's a point well taken.
Hi, Bruce.
Yeah, go ahead.
Bruce Smiley. I'm with Encore Health Network. We're a PPO based in Indiana. I'm just kind of curious with the divide, in the Medicare and the pricing analysis, which is very interesting. If you've thought about correlating that with the consolidation that's also been going on in the payer market. Like when we look at some of those states, Indiana in particular has been shown by a couple of AMA studies to be maybe in the top 5 or 10 least competitive markets in the country.
On the payer side.
On the payer side, yeah. And you know, that's kind of an interesting piece of that because some of it may seem a little counterintuitive in that you would think with the consolidation of payers and that weight coming behind, you would not tend to see that widening gap. And as some of the states are kind of mixed in those results I see up there, I just thought it was interesting correlation. Wondered if you thought about putting that up there with your data.
Yeah, the payer concentration on the payer side, I don't think we're going to talk about in the report at all, but definitely, you know, the state level results, it makes sense to link this up to market shares on the payer side. You know, Michigan and Indiana are both dominated by a Blue Cross Blue Shield plan or an Anthem spinoff. They're highly concentrated on the payer side, but we've had very different outcomes in those two states. There's something, so, you know, I see studies that make it clear that consolidation on the payer side tends to lead to lower negotiated prices, but your state and your market may completely violate that tends to result. So yeah, the consolidation on the payer side clearly matters, but there's a lot more kind of idiosyncratic history going on in all these markets.
Okay, thank you.
Chapin, good talk. Kathy Donison from CalPERS, California. I lived through your chart where the big line was going up and the other was staying flat. So I just wanted to offer a few thoughts about what the market was doing in that slide. And if you'll think about it, in the early 2000s, the HMOs had come in and the regulations actually started in the 90s. And then we were seeing very high inflation in the HMO market and the PPO in 2003, which we had an aggregate 26% increase between 2002 and 2003, and a lot of that was driven by inpatient hospitals. So over time, we had to do a lot of work in looking at not just what was driving that disparity in pricing, but what our networks looked like. Your comment that they did it because they could is partially true. In 2004, Kaiser, one of our biggest providers, had a 25% rate increase. So I would not like it to just be thought of as consolidation issues. There was a lot going on. Pharmaceuticals were inflating at 30%. And don't think pharmaceuticals are just outpatient. Those inpatient prices are very high and about 3% of what we spend in terms of pharmacy. So thinking over time, some of the initiatives that we were driven to generate to keep those costs down came exactly from that separation of high inflationary period, movement from inpatient to outpatient with continued high inflation, and that's kind of what we had to do in those early days to get down to where we are. So I just wanted to make sure we didn't try to lay it all on consolidation.
No, that's great. One more question, or are we? We're done. That's right.
Keep our primary care physicians independent.
Please join me in thanking Chapin for this outstanding presentation. Super, guys.